Good. I'm delighted to introduce Professor Audrey Dorélien. Professor Dorélien holds a PhD from Princeton. After Princeton, she was a Robert Wood Johnson Foundation Scholar at the University of Michigan. And then she was for 10 years at the University of Minnesota. And recently, she has joined the University of Washington, where she's an associate professor and also the training for PI at the Center for Studies in Development and Ecology at the University of Washington. Her research agenda strives to elucidate how human population dynamics and behavior intersect with environmental conditions to affect health. She has done very interesting research on seasonality in sub-Saharan Africa, and also has looked at how this birth seasonality impacts infectious disease dynamics and optimal timing of post-vaccination campaigns. Extremely timely, COVID and everything that we are seeing. Her more recent work analyzes the effects of early life exposures on child health in sub-Saharan Africa, but also in the United States. She has also examined contact patterns in the US and has modeled those contact patterns. Today, her talk is titled Measuring and Modeling the Impact of Partisanship Differences in Health Behaviors on COVID Disease Spread, a timely topic to look at partisanship differences as we enter week 2 of this new administration. So thank you so much for coming.
Thank you so much, Leticia, for this kind introduction. I'm really excited to be here. I did my undergrad at Swarthmore, and for grad school I was at Princeton. So so I'm very happy that the Philadelphia won, and actually very happy. This is my first time at the PSC, so I'm very excited to be here. The very first time we presented an earlier version of this paper was November 1st. So right before the election, and now some updated results with the start of the new administration. So maybe it's useful, but I do think that I guess the key takeaway that you all will get from my presentation is that I think it's really important to think or to incorporate and these partisanship differences. And that's because there's been a lot of research that has shown that over time, Democrats and Republicans have become more ideologically divided. So this was a paper that was showing up to 2014, and we can argue that probably after 2014, these ideological differences have only widened. And this is important because these party political partisanship, some of these differences, they impact many factors. It impacts our views on the economics, the books we read, even the cars we drive. So it permeates through many different factors. And there's also been a lot of research showing these partisanship differences in trust in science. So there's research where Democrats are more receptive to advice from scientists compared to Republicans. And I think basically then, so that trust in science has also extended to partisanship differences in health behavior. So this is not new. People have studied these differences. So prior, during the H1N1 pandemic, people have shown that Democrats were more likely to get the H1N1 vaccination compared to Republicans. So this was even before the pandemic, the COVID pandemic. We were already seeing some of these partisanship differences. And while there are some other people who actually view vaccines as like not at all effective. So this is just to highlight also pre-pandemic research that was also already showing that maybe some of these partisanship differences, and also I think this paper argues also some policy differences in cases with more Republican versus Democrat were already leading to differences in mortality rates across counties that were more Republican versus Democrat. But we can all argue that the pandemic has highlighted or intensified these partisanship differences in health. So party affiliation is associated with different health-related behaviors. And then there were some of the studies that showed that excess mortality for COVID-19 was significantly higher for Republican voters compared to Democratic voters. And this is one paper. So this group of Dorélien et al., they published many papers where they were focused on the behavior, and we see that across a wide range of health behaviors, Democrats were more likely to wash their hands, avoid contacts. So there's the differences in behaviors and also attitudes. And when they measured that across different waves, survey waves throughout the pandemic, you see that those widen, and basically they did not narrow, and that they remain. So where does what do we contribute? So here I'm showing that infectious disease models have not taken into account these partisanship differences in health behaviors. So the mathematical models that study don't incorporate this heterogeneity by political affiliation. But there's been actually recently a call that that's actually saying that it's time to actually incorporate it. And in this paper, we'll actually show you what, and incorporating some of these behaviors, what are the impacts. So this is one quote, but I think this was in Science. And it said the success of biological approaches, such as vaccination, to the prevention and treatment of disease is critically dependent on various social, political, and cultural factors. So during the pandemic, we did a very good job in terms of the biology, the technology, some of the vaccine advances, but we did a very poor job in understanding some of the social behavioral aspect. So our contributions, are really to see, so the first contribution complements some of the existing research is what's the association between political party affiliation and health behaviors. So the key thing is that we directly measure these impacts. So we look at differences in contact rates, so interactions with other people, mask use, and then for one wave of data, we have information on vaccination. So it's not intent to vaccinate, so it's self-reported behavior. And then I show what are the implications for the spread of infectious diseases when you have this heterogeneity. And then there's one piece that I'll talk at the very end is we were also interested in whether or not there was preference dependence behavior. So that is when mortality rates or cases are high, are people taking more protective measures, and whether or not that varies by party affiliation. And that's just because in the, I guess, the economic epidemiologist during the HIV crisis, the impact of prevalent dependent behavior was shown to be important. So why does this matter, and how can demographers and people like me make a difference? So this is where social contact surveys can play a role. So COVID is transmitted through interpersonal contacts, but also there is the airborne, the respiratory aspect. So in the contact surveys, individuals are asked about their activities and contacts in the previous day. So we have information about the number of contacts, the age of those contacts, and the sex oftentimes. But now these surveys also collect detailed social demographic information about respondents. So our survey, we also had information about their party affiliation and political beliefs. We did not ask that in the survey, but the panel had that information already as a baseline. So yes, these, and actually I do want, if people have questions or want me to repeat or clarify, I do appreciate clarifying questions. So these social contact surveys typically collect information about the number of contacts, then the duration, the nature, so whether or not that contact involved physical touch or not. And then there's more, some waves also had information on while you had that contact, were you wearing a mask, and the person's vaccination status. So these are the types, so specifically in this analysis, I'm going to take advantage of the information on the number of contacts and information on mass use and vaccination status. So this was from the Berkeley Interpersonal Contact Study, and I think I forgot to mention this in my first slide. So this is joint work with Chris Soria, Aisha Mahmoud, and Dennis Feehan, and my 3 collaborators are based at the Berkeley Demography Department. So during the COVID pandemic, the Berkeley group collected 6 waves of data, so we have data, empirical data from April, May 2020 to May 2021. For the information on vaccination, it's only under 6th wave that we had the information on vaccination. And I just want to highlight that in terms of our ability to get prevalence-dependent behavior, so during the different waves, so here, this is the different waves of data collection. Let's see if I can have my mouse. I'm not sure I can claim, but you can see that the number of cases varied. So particularly in the December, that Omicron wave, winter 2020, you had a lot more cases. So there's some variation in the number of cases. And when we were trying to get historical cases, we actually went back to the data to see what were the cases reported at that time, because afterwards people updated, but we did it based on the cases that were reported at the time of the surveys. Okay. So this is where I just want to highlight some of the differences. So to give you a sense of the magnitude of this relationship, so here, this is before controlling for any factors. I just want to highlight some of these raw differences. So, and the way you interpret this graph, so on the x-axis, I have different social demographic characteristics, and the bar graph is always the difference between the top group, so young, which was under 65, old, over 65, and dependent versus Democrats, Republicans versus Democrats, and so on. But basically, you see that when we're looking at differences in the number of contacts, the biggest group was the elderly had significantly fewer contacts than the young. But the next biggest group was actually the difference between Republicans and Democrats. So that was bigger than the white, non-white differences or the gender differences. When we look at differences in proportion that wore masks, once again here, you see that the partisan differences actually exceed the magnitude of the age differences. So basically you saw that Republicans and independents were way less likely to wear masks compared to Democrats. And I think maybe the only other group that might exceed was the college, no college. Okay. So this is, and when you see the vaccination, once again, you see that there was huge partisan differences in the reporting vaccination. And I think these differences may actually increase if I incorporate information on whether or not they intend to get vaccination. So here was just whether or not you were already vaccinated. It didn't account for people who wanted to but hadn't yet become vaccinated. And some of them, what's interesting in the raw data is that this is despite the fact that on average, Republicans were older, and yeah, were more likely to be white. So this is despite to me, what was surprising is that despite the differences in their age. So this is just preliminary data. So then the first part of the analysis that we did is that we use multivariate linear models to really understand some of these differences across our outcomes, the social contacts, percentage of mass use, and vaccination rates. And then we also try to understand to what extent other factors may be affecting that relationship. So we had controls for state fixed effects. We had control for whether rural, urban, We even had the mortality rates in the counties, mass mandates, because we know policies played a role. Household size, so a full list of controls. And so I'll actually show. So basically, I'm going to show you the results of when I have a model 1, where I'm just controlling for structural controls. So these are to account for differences in day of the week. Because obviously, or previous research has shown weekday versus weekend is going to be differences. Then differences in social, accounting for social demographic controls, then also accounting for those contextual factors. And throughout my presentation, Democrats are always going to be in the color blue, red for Republican, and green for independent. Yes?
Okay, well, just quick clarification question. So this is for a representative sample of the US?
Yeah.
The survey was done
Yeah, so
by
there's
phone, I mean, just.
Oh, I can, yes, I'm not giving it, there's others, so Aisha and Dennis have published a lot more on the big survey. So if you look, they have one in Nature Communication, showing, detailing a little bit more background on the survey.
A little bit about it.
Yes. So the big survey, so it was an opt-in survey where they did both try to get national, so it's national, so throughout the US, but they also, it was a combination of national and also some cities and state. So actually they had a lot of data for Philadelphia, some of the major cities. So it's a combination of both, but then we use weights to try to make sure that the opt-in then was nationally representative. It was online. So it doesn't have, so there could be some bias where it won't have the people who don't have access to online. What else? Trying to, I mean, so there's something. So online, it was retrospective. So you asked about contacts on the day before. And then the sample sizes were pretty, big. So about like the sample size varied about between like 2,000 to up to 5,000 respondents. And I think it did a pretty, I think with the weights, it did a pretty, there were post-sampling weights to make it nationally representative. See 6 waves. And I can answer maybe a little bit more about the specific bits sample afterwards.
So, but then it's not the same people in follow.
No, it's not, so no, it's cross-section. Cross-sectional, it's not the same people, so although, so it's not the same people over time. Any other question? Okay. Yeah. So here, we really wish we could have the longitudinal, because the longitudinal, I think, then would better able to study like some of the prevalent dependent behavior or control, because then you could have within person fixed effects to see how that varied over time. But at the time, it was just cross-sectional. But here, in this figure, you have the model 1, model 2, model 3. And basically you see in the model where we just control for weekend versus weekday, you see there differences in the number, probably the predicted number of daily contacts between Democrats and Republicans. But the key takeaway for me is that even when I add our full set of controls, including contextual controls for differences in policies and cases, you still see that there's a statistically significant difference between the number of contacts for Republicans and Democrats, with independents being somewhere in the middle. Yes.
Yes. Maybe you just answered, but to which extent does this account for being, on one hand, exposed to different lockdown rules, and I guess to the other hand, working in different companies or being in different schools that implement it?
Yeah, so in our country.
So I guess which is a choice as compared to the result of basically exogenous.
No, so that's why we actually controlled for, so we have information on their location. So we added county level, whether or not it was urban or not. We had information on whether or not the respondent was in the county with the mask mandate. Yeah, so we try to control for some of that. And I thought that once I control for these county level characteristics, I would not see as much of an effect. So I'm surprised that in model 3, controlling for that, I do see some of that effect. And there's some analysis here that I'm not going to show you, but there's a part where we know their location. So we actually have an analysis where we see how does who you're surrounded by influence your results. So we have the information where we know if it's a Democrat who's in a primarily Republican county, what does that look like? So basically you had that if a Republican is in a primarily Democrat county, that Republican still has much higher level of contacts than other Democrats. But if a Democrat was in a primarily Republican county, they started looking a little bit more like Republican, but still different. But you saw some, so I think Republicans, regardless of context, were less likely to change, or Democrat in the primarily Republican started to look a little bit more like Republican. So that's some piece of analysis that we're not sure can fit in this paper, but we do have it, and I think I may have it in some of the extra slides. So that was us trying to get at some of the impacts of this setting on behavior. So yeah. So we see that with masks, so in this one, you see that across all the models, Democrats were way more likely to wear masks compared to Republicans and Democrats. And when we got vaccination, so vaccination was only for one wave, you see that in model 3, once you control for the different factors, they're closer together, but there's still statistically significant difference between the probability of vaccination for Democrats compared to Republicans and independents. So does this matter? So how does incorporating partisan differences in health behavior impact COVID-19 disease transmission? And just a little background, I don't know how many infectious disease folks there are here, but I just wanted to highlight that usually when you think of an epidemic, you traditionally people sometimes separate the population to susceptible, infected, and recovered. And basically this, I'm gonna show you specifically your model, but you see that there are not the expected number of infections generated by a single infected individual in a fully susceptible population. That's influenced by the contact rate, the duration of infectiousness, and the probability of infection given a contact. So here in our in models, if the contact rate goes up, the R0 goes up. And then if your rate in which you're masking or doing other protective behavior goes up, then that means your probability of infection per contact goes down. That decreases R0. So how do we approach to doing this with the 3 different parties? So here we have a 3-group SIR model, each with 2 subgroups. So we have Democrats, Republicans, and independents, and each subgroup has an unprotected versus protected population. And protected means they're taking protective behavior. It's not the same as the recovered, where people have immune. So we do the and yes.
So in your context and using your data, protected means they did all 3 or they did one but not the other?
So protected. No, so here in terms of vaccination, you'll see in the model we do it separate from the masking. So the protected are things like, it's really masking or capturing, but I guess you could think of it as just overall other protective behaviors that reduce the transmission probability, but don't give you full, it's not full protection. It just but we were using the information for masking to be a protected,
Just a quick clarification there, and this is about the potential transmitter, right? It's not about like their contacts because we don't have that information.
I'll show you, so I
Okay.
do, so I'll break down. So these are just the thing, so the key here is that I'm assuming, instead of assuming one big population, I'm assuming that the population has 3 groups, 3 political, and within those groups, there's people are protected or unprotected. So within one, so for each group, if I'm looking at the unprotected, this is where I have the SI, or the susceptible, infected, and recovered. So here you have susceptibles to who then go into the infected but not recovered. And when they're infected, there's the part where they die, so there's the mortality from COVID. And then there's some infected that obviously the majority recover. One aspect in our model is that we have waning immunity. So you're not permanently in the recovered group. Over time, you go back to becoming susceptible. Then we also have the protected group, where it's a mirror where we have the susceptible, infected, and recovered. But there's the difference between the protected and unprotected is the scaling factor kappa. So it reduces the probability of transmission when protective behavior is adopted. Let me some of my notes. Okay, and I guess I want to give a little bit of information. That lambda that I have here, people are not just interacting with other, so it's not just protected or only interacting with protected, and unprotected or interacting with unprotected. So lambda, really that force of transmission, it's a combination of the contact rates, so the contact between the groups, but also the share of the your contacts that are protected and unprotected. So the key takeaway is that if your contacts are higher, the force of infection is going to be higher. And then if you have a higher share of unprotected, your force of infection is going to be higher. So you can think that Republican they have higher force of infection because they have a higher proportion in the unprotected, and from our data, they have higher contact rates. Yes.
So here you assume the same recovery rate and the death rate for the protected and unprotected group, but we know for people who are vaccinated, they often have more mild symptoms.
So for vaccination, I'll show you where I haven't shown the vaccination yet. So for vaccination, we only have it start after the first year. So first of all, so I'm assuming this is like the beginning, where before we don't have vaccination. So when we have vaccination, we are actually gonna treat vaccination taking the susceptibles into the recovered rates. But even then vaccination, you still don't have that waning immunity. So vaccination is so I think the vaccination, I just have it that way. I don't have vaccination as necessarily we do. Well, I guess the vaccination, I have vaccination being very effective, where it immediately puts you in the recovered. So that part's a little more simplistic, but because I only had one wave, I'm not gonna focus on vaccination as much. And also for that, in this model, I don't have age compartments. I don't have, so here and we know that for vaccination, the effectiveness and also the age really matters. But the one way I take into account age is that I do have a higher mortality rate for Republicans because they're older versus Democrats. There's actually one other piece about contacts that I want to highlight. So how do I include contacts in our disease model? So here for simplicity, I'm just going to focus on two groups. So when we have Democrats and Republicans, we have Democrats are interacting with other Democrats. And then Democrats are also interacting with Republicans. And likewise, Republicans are interacting with Republicans. Republicans are interacting with Democrats. So what do we know? From our data, I know the total number of contacts. I don't actually know what share of the Democrats' contacts are with themselves or with Republican. And likewise, I don't know. So I know the average number of contacts for each group. I don't know the share. And it's important. So we know this, yes, I know the average number of contacts. So there's another parameter called homophily. So homophily is the share of that group's contacts that are with each other. And the homophily you can think of is going to be influenced by the number of contacts, but also the size of the population, right? Because if there's, so if a Democrat is in a place where there's mostly Republican, or a higher share of the contacts is gonna be Republican than in a place where the population is 50. So there's a part where in our analysis, I'll show you some model results where since you have three groups, I'll first assume that the homophily is the Republicans is reflective of the equally, like the population divided like 1/3 each of the parties. But then because I don't think that's realistic, we'll do some sensitivity analysis where we show you the impact of varying homophily and also varying the size of the Republican population. So another aspect about the model is that the individuals move between the two groups. So we have pi, the rate of adopting the protective behavior, and we have phi, but there's a part where over time, you can think like most people are not gonna wear masks forever. So there's also that waning of the protective behavior. Okay. And some of these were taken from other people that have published some models. So what are the key differences between the parties in their model? So in our model, what we vary is the average number of contacts, the homophily, the rate of adopting protective behavior, the rate of waning of protective behavior, and then we do vary the mortality rate where we have Republicans are older on average. And then some factors that are not influenced by behavior is that like our lambda with we have the same lambda transmission given contact, but we have the recovery rate, waning immunity, and then the scaling factor. So here we said that the scaling factor we did 0.7. So if it was 0 means full protection. So we're assuming some protection, but it's not fully, it's 0.7. Just how effective were some of the behavior? Yes.
Can you explain how, if mortality rate varies across these groups, how recovery rate wouldn't? Because either you.
Yeah, no, so then it will. So I do think it, since it's, so I do think it,
Got it.
or the proportion that then it will,
Got it. Okay, thank you.
So what does this look like? So first, in the null model, so we have a null model where actually in the future, I'll show those as dashed lines where, and there's gonna be 4 outcomes, a few different outcomes I'm gonna show you. So here, I'm looking at the proportion of the population that's infected and the cumulative proportion that has died. And basically in the null model, what I did is that we average Republican, all the contact rates across the population. And then we also assume that the population is equally divided among, the size of the population is equally divided amongst the group. So I'm gonna first compare a full model. So there's a part where we can, here I'm including most of the differences between parties, but there's also versions of the model where I just hold everything else constant, but just vary contacts. See just what happens when you just vary mass. So if we have extra time, I can show you these, but this is incorporating all the partisan differences that we were able to infer from the data that we got. So here now, so the nulls, the dash. So we see that in our model now that takes into account these heterogeneity, we see that the timing of that first wave moves is earlier and the magnitude is a little bit higher. And we see that, and then in terms of the total proportion that dies, we see that, peak is 4.5 higher, occurs 7 days earlier. And at first there's higher mortality, but then eventually we approach the null model, but I think are always a little bit higher, more deaths than in the null model. This is the same figure, but now I'm showing the partisan differences. And I want to say on the y-axis, it's also the proportion infected within that party. So you can see that if we look at those partisanship differences, we see that now that we incorporate those heterogeneity, the Republican have 16% more cases than the Democrats. Republican deaths exceed Democrat deaths by 75%. And why is the difference between the cases and the deaths so different? Part of it is the differential mortality rate on top of the contacts. Like that. Okay. And this is where vaccination. So in our model, we can also include vaccination. And the way we're modeling it right now is that you're vaccinated. So the rates of vaccination vary. Where from the vaccinated is the unprotected. Yeah, people go from susceptible to recovered. But for vaccination, we only have data towards the end, so I think we started at day 365. So if I show you those same results with, and now my x-axis is always time here. So if I extend the model, then you can see like the second wave happening. Vaccination is actually, yeah, so here, Republican cases exceed Democrat cases by 20% and the deaths by 80%. The reason why I would expect even bigger differences, but vaccinations happening after the first peak. So if I were to do a different model where it's like, oh, let's say from the beginning we had a vaccine, then I think you could see that the differences, the partisan differences in vaccination would be a lot bigger. And I think from our data, let me see, if I had, yeah, so in terms of our data, from the VIX data, Republicans were 23% less likely to be vaccinated compared to Democrats, and independents were 17% less likely to be vaccinated compared to Democrats. Yes.
So do you know if these people have already had COVID or not?
Yeah.
Because that could potentially affect their decision to vaccinate or not.
Yeah, so in this data, we don't have it. So that could be, so I think here, you could assume that another reason why vaccination is not having a huge effect is that, so even though the Republicans, let's say, are not getting vaccinated, a lot of that population has the disease-derived immunity, let's say. So here, I don't have that information under, and yeah, but that's, yeah, so I think some other studies, or if I did at the beginning, like I do think vaccination does play a role, but in the analysis that I'm doing here, because of when we implement it, we don't see as much of an effect, but I do think studies, like we do want to make sure we capture partisanship differences in vaccination, because I think that it's only going to probably increase with some, yeah. And I think now it's not just COVID, some of the routine, well, actually, it's interesting because sometimes there's some liberals that then are, yes, I think it's interesting to see what that might look like, but we do want to capture.
Go both ways.
It can go both ways, yeah.
If you have COVID in very bad form, so to speak, you know, you might choose to get vaccinated.
Yeah.
But if you just had it without even knowing, you know, you might not.
Yeah. Yeah, so, and I do, yeah. So I do think the perception, there's some studies that's like perception. Oh, so I think we had some question actually, your perception of risk, of like how risky or how concerned. So from our data, we could actually see how that's correlated with whether or not you get vaccinated, but I don't think we've done that, but we do have how concerned.
Your model, you did have some parameter for recovery.
Yes.
So when you see those other people that their infection rate is lower,
Yes.
so you have built something.
Yes. All right, so now, given the state that we live, so here I was assuming kind of those first results, I was not having a lot of homophily. So basically, and also the population size was equal. So the first piece here, I'm keeping the population size, you know, a third. But I'm seeing what's the impact if I'm assuming that now Republicans are intentionally interacting more with Republicans. So what happens if homophily is 80%? So we see that here, if the proportion infected, there's not actually as much differences in the magnitude, but we see the peak occurs a lot sooner. And this is actually, I wanted to, instead of just doing a one cross-section, I'm like, okay, let's actually vary homophily. And we have a parameter, it's like 1 to 5, but 1 corresponds to homophily of about 38%. So 38% of Republicans interacting with each other. 5 is 82% of Republicans interacting with each other. And you see that when you increase homophily, at first peak cases go up a little bit and then decline. But homophily, where it really plays a role is in the timing of the peak. And actually, these differences are not as large in terms of the magnitudes of the peaks. And so, yeah, so increased Republican homophily can be associated with actually declines in the total number of cases. And now, if I just go back to looking at the 80% homophily, you see that if I'm looking at the peak for the Republic within a location, you see that the Republican peak is way higher and sooner. And for Democrats and independents, it's lower and later. So proportion of Republicans infected is 25% higher. Peak occurs much earlier. But then this is where other research that have looked at heterogeneity in these different groups have looked like this is when you can have complex epidemic curves. So you could have a place where you first have a peak and you may assume it's going to go straight down, but no. Then you might have a second peak, a second where the other group that's taking more time. And here, I'll say one thing. In our simulation, when I'm looking at these, I'm seeding where I'm starting with one infected individual Republican, one infected individual in Democrat, and one infected individual in independent. There's some other papers that have been published theoretically where they just have one infected individual in the high risk group. Then you could see even more like different complex epidemic, because where their homophily would really delay the time that then it spreads to the lower risk group. Here I'm actually seeding it simultaneously in all the groups, but you still see the potential for some of these complex patterns. All right. Now, if I look at homophily and I increase homophily and I look at the number of deaths and then bipartisanship, we see that homophily did a slight increase in total deaths, because I said that homophily was actually associated with a decline in cases, but we still see a slight increase in total deaths. But that's because the Republicans had got higher death rates. But overall, Democrats and independents benefit from more Republican homophily. And that's because the high-risk groups mixing more within themselves. So share of deaths among Democrats and independent decreases with increasing Republican homophily. Okay. So now, if I vary the population that is Republican, so here, if I go from 20% of the population being Republican to 70% of the population, so that's the yellow curve, you see that increasing the share of the population that's more the high-risk group really increases the magnitude and makes the peak occur a lot earlier. I'm going to break that. But actually one piece though, so I'm not going to show that figure here. If I were to break this down by parties, you'll see that for everyone it's earlier. So the magnitude for Republicans is going to be way higher than Democrats. But the peak moves earlier for everyone. Versus, so it's different than the homophily, that the homophily kind of changes the relative timing of the peaks. But yeah. All right. So here you see that like when you increase the share of people in the highest group or the Republican group, peak cases increases monotonically, increases with increased share of the population, and days to the peak decreases. So here I see an 8 percentage point increase in the peak number of cases, and now the peak occurs 40 days earlier. And then when I looked at deceased, you see 4 percentage point increase in the proportion of the population that has died. And everyone now is worse off. So yes, so you see that as the share of the population that's Republican, that increases mortality for the Democrats and independents. But what was interesting is that here the curves stayed parallel, so it increased. While remarkably, there was actually some divergences that happened. Okay. So this one other aspect that I mentioned is what about prevalence dependent behavior? We actually didn't find that in our empirical results, we didn't see that people actually were responding that much to cases. We saw people were responding to mortality, to deaths more. So in our model, we actually can, before I wasn't including this, but you can actually have that the average number of contacts respond to lab deaths. So we have a parameter as zeta. And what's the empirical evidence from this is that in our analysis, we saw that actually it was just Republicans that were reacting or that was changing their number of contacts based on the number of cases. One criticism, so I do think that's happening. I think there's one issue in our data is that we're starting in April 2020. So the Democrats already have low contacts. So it might not be that so I don't think that the Democrats necessarily don't respond to cases. They may have already reduced their contacts to a number where there's not much room for movement. So I actually think it's really important to be able to see to what extent this is happening and to what extent we do see differences between parties. But since in our data, we did see that Republicans were during the Omicron, let's say they actually reduced their number of contacts. We do model, here I'm gonna show you what happens when I model that. So when I model that, so with data with that, it should not be prevalence, mortality dependent behavior. I actually then do see that the peak still happens earlier, but it's actually smaller than in the model with than the null model. Yeah, and basically, but what I found interesting though, even with this prevalent dependence behavior, these results are still similar to when we didn't have it, where Republican cases still exceeded Democrat cases by like 70%, and Republican deaths exceed Democrats by 76%. But the overall level is like, everyone's, it's with prevalent dependent behavior. I think the cumulative level of deaths is lower for everyone. Because that high risk group is acting safer, but there's still some of these differences. And why am I on time? Okay. But there's still some limitations, and then maybe I might show one. My Chris actually did a figure for Philadelphia that I want to show. But there's some limitations. So we have self-reported health behavior. So there is a concern of social desirability bias. So basically, is there a concern that Democrats are more likely to report fewer contacts, even though they may not have, compared to Republicans? But there's some actual evidence that showed that this is not likely the case. And then also, I think it helps that in our data, I wasn't priming necessarily people. We did not ask people about their party affiliation. We already had that data from the survey provider. We have no information about the contacts, our respondents, their contacts party affiliation. So the ways of what are some of the ways to be able to measure homophily? So one way to kind of think of this is maybe do some case studies where we think there might be more homophily. The issues that with the US and geographic polarization, I think places where there's a lot of Republicans interacting with Republicans is because there's just a higher fraction of Republicans in those settings. And then more studies on the presence of this prevalent dependent behavior. So I think there's some evidence in the data, but from other epidemics, we know sometimes this occurs. So it'll be interesting to know if this happens. This disease model was not age stratified. But I do try to take into account some age with the differences in the mortality rates. Could be some uncertainty about the model parameters. And here I show you the results of the 3 groups. We also had a simpler version where we had the 2 groups, but I think now there's a lot of data to go through. I think we want to systematically compare to see whether or not that third group, that independent, alters the data. And right now, I don't see big differences between the two group model versus three groups, so I do want to say it. And here we always talk Democrats, Republican, but independents are actually a huge share. Oh, and then another thing is that here I showed you some of the homophily, the polarization, but I think the political science have been studying a lot more effective polarization. So there's some disease models where you can have outgroup aversion. So what does that mean? So there are some instances where it's not just that there are differences, but if that people are purposely behaving the opposite way as the other group. So that, like, let's say, oh, if Democrats get vaccinated, now I'm not gonna get vaccinated. So whether or not, so that could lead to even more differences, divergence in behavior. But I don't know to what extent that is happening. But I guess, yeah, here it's Democrats and Republicans, very different, differently in their contact rates, mask usage, and vaccination rates. Here we're just really illustrating one way to incorporate these differences in disease models that's not typically done. Partisan differences in health behavior impact both the magnitude and the timing of the epidemic. And yeah, there's the importance of homophily, the relative size of the high-risk population. And we see this really as a first step. There are many more interesting modeling questions that we could explore. And then our study also identifies important empirical quantities that we have really little empirical information about. So some of like this homophily. So in terms of funding, it comes from Berkeley, and also for me, most of this work was when I was at Minnesota. But actually, I want to just show one thing and then I'll end. So this is actually Chris just put this together for BICS because we had a lot of data for some cities. This is actually what happens when I put the Philadelphia population, like, you know, what proportion of respondents were Democrats, Independents, and Republicans. What does that look compared to a null model? So here we see, so Philadelphia is mostly Democratic. So if I was, so I see compared to the null, cases are actually smaller than you would expect. And yeah, so, and mortality is less than if you assume that everyone had if you assume the composition, well, it was homogeneous. But you still see, even within the setting, these are proportions, so these are not total magnitude. But you just still would see that within Republican, there will be a higher proportion that are infected compared to Democrats and Independent, and likewise the deaths. Yeah. So with that, I'll stop.
I guess in modeling, there's a trade-off between complexity and simplicity, right? If your model's more complex, they're in theory better, but you introduce lots of parameters you don't know anything about and you make it specify. So I guess a question at the end of the day is which captures better reality. And I guess this is I didn't see well in your model. So, right, you introduce this complexity and somebody says, good, but if you ask what captures better reality, which one of which models is actually better?
So I think the models, yeah, so I don't, so I think, yeah, so how this, well, I guess I'll go back. So I do think the models should at least consider some of the partisanship. So I think some of the protected versus not protected, some of like that level of detail, maybe we could simplify the disease model, but I do think not capturing this heterogeneity, I think that's a mistake. And I think the infectious disease, there's been a lot of theoretical models on the heterogeneity is important. So I do think that piece, but I think when you have the heterogeneity, parameterizing it becomes hard. So that's why I do think we demographers or need to help inform or see how to capture it. Because I do think it matters. So this was a data where Chris had just looked at the county levels population. So here it's not age standardized, but we do see that within we do see these differences where like counties that were mostly Republican, especially later on, had much higher deaths compared to counties that were Democrats. So I do think that matters. So I think it matters. And I don't think in the US our models did not do actually a good job. So whatever we were working with was the null that didn't take that into account. We did not do a good job. And so I do think that we need to see, there's some people who are taking starting to take into account racial differences, partisanship differences. I do think we need to start taking into account some of these social demographic, because they do matter. But there is that trade-off. Yeah, so I think what I don't do is empirically test that, but just because, this one thing, because we were saying, ideally, I would want to have like mortality data by, so even at the individual level, like the mortality, the death certificate don't tell you your party affiliation. We don't, so I think there's some of the stuff like how to validate or how to test. So those are some of the stuff that is works in progress. But I do think it's capturing something that we weren't before.
What mortality data did you use? How did you model mortality?
All right, so for mortality, what we actually did, so we knew the age structure. We have information of the age structure of the Republican versus Democrat. So I think we did the age standardized mortality. So I think not age standardized, screwed. So since we are not using a age compartment model, so we did it based on the composition of the Republican. I forgot where because that was
national data or did you do?
no, this was national data. So I think we went and searched. Yeah. So it's
There are estimates of excess mortality at the county level.
yeah. Okay.
Good, if you have county data, it
Yeah.
would be better than using national data.
Yeah. So I think for
I wonder about the mortality component of that.
yeah. So I guess if we do some case studies, yes. Not really like do count or something like do count. Yeah, so I'll have to double check. Oh, so you mean just what mortality did I? Yeah.
How did you model mortality?
Oh, okay. Yeah, no. So when we
It's okay, we can talk about it later.
yeah, no. So I do
I'm not
actually
sure.
think we had no. I think I misspoke before. We did have actually when I was looking at the prevalent dependence, we had county level mortality there.
No, we can talk about it,
Yeah.
so other people can ask a question, but
Yeah.
I was
Yes.
just wondering if we have information about these baseline contact differences between Democrats and Republicans, and I would imagine that there might be, I mean, not that you would want to incorporate that necessarily directly, but I'll be curious if some other survey of some other,
Yeah. So
collects information on that, and if we have any sense of,
so
yeah.
yeah, so the US did not collect social contact data. We don't have good historical social contact data for US. So we're not able to see at baseline what it was. But now people are continuing to collect. So this is not the pandemic. So actually now with some of the data we are collecting, we can see if they're always is it just during pandemic or during outbreaks or this, do that reduce? Are they more similar? Yeah, so but before the data that we have before, we could not, I cannot easily tell. So those are some stuff where we wish we had it before. Yeah, but yeah.
Same line, I think, I wonder in which extent, for example, the risk aversion can kind of explain this behavior. It's just a matter of health behavior or also some kind of risk aversion. Okay, I don't care. COVID is not a big deal, so
Yeah.
I don't have to take some.
I missed the first part of the question.
I'm just wondering if this is risk aversion can be, for example.
That's the word I'm missing. Risk conversion, okay. So you say whether or not that's the risk conversion. So it's just to interpret this, is it that the fact that they're not so instead of political affiliation, it's just perceived risk that's playing a role?
Yeah, they are correlated.
Yeah, so that we I will have to look, like, we can look, we do have information about risk. So yeah, so that's other studies that I think we should do to see what is that political affiliation capturing? Is it just differences in perceived risk? So that I would have to look at a little bit.
So with risk aversion, we will, thank you so much once again.
I was like, how was that? No, no, that's
Wanted to. Hi, how are you? I'm not running to you. No, I'm not. Yeah, so when.
MBA.
Oh, right. Yeah.
Even when Biden.
Yeah, I have my voice.
It's not like.
Something else.
Yeah, no, yeah, because it's not follow the same people, but we have the cross section, but at every group, you still see those differences.
It's just a social stratification
The
underground.
differences are always, like, the level will have varied a little bit by wave, but the differences will. Because I think there's sometimes where people relax, like, oh, it was bad, and then people were angry, yeah.
That fits my understanding of everything.
No, thank you. No, we hope that they